So why don't we go ahead and get started today? Let's begin today's program entitled Improving Maternal Health Through Universal Health Coverage. My name is Sandeep Bathala, and I'm the Senior Program Associate who works on the Maternal Health Initiative here at the Woodrow Wilson International Center for Scholars. So lots of familiar faces. You may have noticed that I said something different in my introduction today. I said Maternal Health Initiative. We have renamed our efforts to truly reflect what we're focused on. So thank you for joining us today. So as I said, this is part of our Maternal Health Initiatives Advancing Dialogue on Maternal Health series. And within that series, we look at many critical and neglected maternal health issues. And it is generously supported by the Maternal Health Task Force as well as the United Nations Population Fund. As many as you know, as I said, I see a lot of familiar faces. The Woodrow Wilson Center is a formal memorial to our 28th president, and in his honor, we bring the worlds of policy, practice, and academia together to better inform one another. I wanted to make two notes about today's meeting. One is that if you are interested in tweeting, we encourage you to use the hashtag MHDialogue, and this slide will remain up through the course of today's event. So if you ever need to reflect back on what that name is, it will be up. The other thing I want to point out is that today's event is being webcast live. So what that means for folks here in the room is that when we come to the discussion portion of today's event, I'd ask that you wait for a microphone. My colleagues will come around with it so that those folks tuning in will be able to hear you. I want to direct your attention now to our esteemed moderator from the UNFPA, actually, Jacqueline. And then we had a slight chuckle because I'm Indianizing her last name. It's not what I want to say, which is Mohan, but Mahon. Sorry, I can't get that out of me. It's in my blood. She is the Senior Policy Advisor on Global Health and Health Systems for UNFPA. So the perfect person for us to lead our discussion today on universal health coverage and maternal health. And I will turn it over to her now. And thank you.
Thank you very much, Sandeep, and thank you very much for joining us today and you're using your lunchtime to come. And it's a great pleasure to be here. And we're very grateful to the Wilson Center for organizing what we very much believe is a very timely discussion. And I'm delighted to moderate this session, and with two very eminent colleagues, Anna Langer and Jonathan Quick, or Jono, as he's told me that he likes to be known. It's, as I said, it is extremely timely in light of the ongoing discussions in relation to the post-MDGs and what those goals will be, whether there will be a health goal and what that health goal will be, and also in terms of the current MDGs and the unfinished agenda, and ensuring that that unfinished agenda is very much incorporated in the post-MDGs. Let me introduce Anna and Jono first, and then I will talk a little bit about, been asked to talk a little bit about the process in terms of the context in terms of the post-MDGs and current developments more generally in relation to sexual and reproductive health and rights. So first of all, let me introduce Anna Langer. She joined the Harvard School of Public Health in July in 2010 as a professor of the Practice of Public Health, Department of Global Health and Population, and the director of the Women and Health Initiative and Maternal Health Task Force. Dr. Langer is a physician specializing in pediatrics and reproductive health expert. She is respected worldwide as a leader in using research findings to influence policy and improve the overall quality of healthcare for women and families. Before joining the Harvard School of Public Health, Dr. Langer was president and CEO of Engender Health, and previously Dr. Langer was based in Mexico as the Population Council's regional director for Latin America and the Caribbean. Thank you. You're very welcome. And I introduce Dr. Jonathan Quick, or Jono, a family physician and a health management specialist. He is president and CEO of Management Science for Health. He is also the senior editor of Managing Drug Supply and has written over 70 books, articles, and chapters. He's on the faculty of Harvard Medical School Department of Global Health and Social Medicine and Boston University School of Public Health, and is a fellow of the Royal Society of Medicine. He serves as chair of the Global Health Council. Dr. Quick was director of the Essential Drugs and Medicine Policy at the World Health Organization, and he has worked in international health since 1978 and has carried out assignments in over 50 countries in Africa, Asia, Latin America, and the Middle East. Very welcome, Jono. We're going to have a very interactive session. There are no presentations. It's very much a discussion, and we want to open it up to you as well so that you also have the opportunity to ask questions in this context. So without much further ado, let me set the context. At this moment in time, as I said, we are moving towards the development of the post-MDGs, and there has been a lot of discussions in terms of that, what that would be. There has been a very strong effort to make the development of the post-MDGs very consultative. A number of sessions, a number of bodies have been established to develop and to inform more generally the process. And I'll talk a little bit about that and what that means in the context of health and what that means in the context of sexual and reproductive health and rights. We have had a United Nations System Task Team on the post-2015 development agenda, and that has been very much a consultation across all of the UN agencies, and a number of thematic papers have been developed. One thematic paper was on health, and there was a thematic session that took place last year more generally to discuss what would health look like in a post-MDG world. And then we've had the report of the high-level panel of eminent persons on the post-2015 development agenda, and health was very much part of that report. And we also have the Sustainable Development Solutions Network, which is being chaired by Jeffrey Sachs. Also, health has been part of that discussions. And more recently, we have the open working group on the General Assembly of the Sustainable Development Goals. And they've had 8 sessions, and one of those sessions was in the context of health. And so the issue is, will health be a goal, a post-MDG goal, and what will it look like? And there is a lot of discussion and debate, and it seems from all accounts that there will be one single health goal, but there is considerable anxiety and uncertainty about that health goal, whether it would be a universal health coverage goal, whether it would be a health and well-being goal, but very much, the emphasis is on really pushing forward on a health goal. In the context of my own organization, UNFPA, we have been very engaged in this process, and we've been very much pushing forward for in the context of a health goal, that there would be a target per se on universal access to sexual and reproductive health and rights, because we feel that it is an unfinished agenda and we really need to continue moving that forward. And we would like to see very much a focus on inequalities in terms of indicators and ensuring the quality of services. I also wanted to bring to your attention that last week there was a launch of the ICPD Beyond 2014 report. It was released last week by the Secretary General, looking at 20 years after Cairo. How far have we come in terms of the ICD program of action? And the report, I would very much encourage you. It's a very detailed report with lots of informative information. And what I've said is that the gains in maternal health and other dimensions of sexual and reproductive health and rights during the post-20 years are among the greatest successes to celebrate since the ICPD. Of all, sexual and reproductive health indicates the greatest gains, and there, in reducing maternal deaths, we've seen almost 50% reduction in maternal death. But we still have challenges, and the agenda is not finished in the context of persistent inequalities, persistent issues around rights, discrimination. So just to set the context in that. So let me turn to my 2 panelists, and I will start a discussion in relation to universal health coverage and maternal health. So Anna, could you discuss why it's so critical to ensure that maternal health and women's health have a space in the post-2015 agenda? And what do you see as the persistent and major barriers to improving women's health?
Thank you. Thank you, Jackie, so much for the kind introduction and for introducing the topic so comprehensively. And thank you all for your interest in this very, I hope, exciting session. So, as you mentioned, the maternal health and the way we usually measure maternal health is through maternal mortality. Has significantly improved in the last almost 15 years now. And that has to do a lot with the fact that we had one MDG, MDG 5, one Millennium Development Goal, the number 5, specifically focused on maternal health. The fact that we had that very, very measurable, concrete goal that was embraced by the global community and also by governments, and that also included very concrete mechanisms to track progress and measure progress, and definitely helped to focus the global attention on maternal mortality. And as you mentioned, the effort has paid off. We've seen a quite dramatic decline, although most countries won't reach MDG 5 by 2015, because the goal was a little arbitrary and established through a process that was very different from the one that we see the UN following this time. I mean, I don't know, for those of you who were part of the global health community in the year 2000, we were almost caught by surprise. We didn't even know that the MDGs were going to be approved and that they would be so important. So I think that well, it is critical that this effort continues. As you mentioned, inequalities are still very, very important, and although we see this decline, the decline is an average. If we look at the situation in different countries or within countries in different population groups, the situation is much more dire than what we see at a glance when we look at that trend going down. So inequalities is a big issue. Vulnerable populations in particular, women living in conflict situations, or women who are part of an ethnic minority, or women with disabilities. There are so many women who don't have access to the kind of care and attention others do. So the agenda is far from finished, and as you correctly pointed out, the sexual and reproductive health is a target that was added to the MDG 5 later, and to a great extent thanks to the pressure of civil society and other NGOs and other stakeholders. And we haven't made as much progress with sexual and reproductive health as we've seen with maternal health, as your report shows. So what are the main barriers, very quickly, because I think that we will keep talking about this during the next hour and a half. Obviously, there are barriers that are health systems related, and barriers that have to do with the social determinants of health and the conditions in which women live. So maybe I will stop here not to preempt the rest of the conversation.
And I forgot, I was to also plug this, this paper that has been written by Jonathan Quick, Jonathan J, and Anna. It was on the table outside, but pick up a copy. It's actually an excellent paper, Improving Women's Health Through Universal Health Coverage. And as I was saying to Jono, we had UNFPA, we had a regional conference with 13 countries in the Middle East and North Africa, and this paper was extremely helpful and informative. So I would encourage you to, if it's not outside, to certainly access it online. It's open access, so no problems. So a more general question both to Anna and Jono. In what ways were the Millennium Development Goals effective for improving women's health globally? And what were the shortcomings of the goals?
You're looking at me, maybe. I'm
looking at you.
I'll say good afternoon. And let me start by thanking Sandeep Bathala and the Wilson Center for bringing us all together. I think that it's always nice to have these events and focus on topics that are important to all of us. And Jacqueline for jumping in at the last minute and moderating us. And Anna, who this article is, I tell folks in our organization, if the first writer in history to become a billionaire through their writing stopped the first, second, third, fourth, fifth, sixth, seventh, eighth, ninth, 10th, or 11th time, we wouldn't have the J.K. Rowling series or Harry Potter. or she wouldn't be a billionaire. So this article started a year ago with a couple of paragraphs, and we got rejected the first time and the second. We didn't get to 12, but it's been fun, so it's nice to be here. I grew up with stories of my great-grandfather, who was a homeopath, who did 5,000 home deliveries. He had 3 waiting when he passed away. And my grandfather, who went into practice as a pediatrician when there was no antibiotics and no vaccines. So when I became a family physician, I really enjoyed taking care of pregnant ladies and couples and deliveries and looking after the kids. And now that I have 3 daughters, it's really good. Maternal health, I think, will soon become even more personal. So on the question, I mean, I think the MDGs, and Anna was right, it was really, the year 2000, there was sort of a millennium fever, if you go back there, and there were a whole bunch of things that really came together. And I think health overall came out the winner, in the sense that we had 3 of the 8 goals. We're fighting now to get 1 of the 12, or whatever it's going to be. But having those goals, having the focus, the advocacy, the resource mobilization, and the focus on results. And some people said, we shouldn't focus down. There was, for a while, a little bit of parts of the European community that wanted to focus on health systems more broadly, because that's in their culture, and others that said you got to focus on results. The conversation in Washington at that point was often that development assistance is a waste of money in the year 2000. So the focus on those 3 goals, health goals, and the persistent focus and advocacy and setting targets and measuring and holding people accountable, I would bet anyone dinner for 2 anywhere in the world, we would not have gotten anywhere close on some of these goals as we've gotten with having these targets. The question of what were the shortcomings, I think the unevenness among countries, and that's always been an issue, and it's a persistent issue. I think the second thing is that probably less in maternal health, but certainly in AIDS, there was a lot of, the emergency mindset was the right mindset at the time. There were a lot of sort of shortcuts in designing programs and getting up to scale quickly. And particularly in the AIDS, TB, malaria, there was a kind of a balkanization of those programs that's now taking effort to bring back together. So I think the verticalism was both a strength, but is now something that we need to deal with. I think the third thing is actually the result of the success across the MDGs, which is that we now have a chronic disease epidemic of heart disease, diabetes, cancer, lung disease. And what people miss is that, for example, just 2 cancers, cervical cancer and breast cancer, in reproductive age women in low and middle income countries kill as many women as as pregnancy and childbirth. But you could be forgiven for concluding, just by looking at the health systems or listening to the press, that women in low and middle income countries don't get cancer. So it's actually, and we could get out all of the other conditions and look at it. And contrary to what Bill Gates says, chronic disease is not just about old people dying. It's people it's children, it's people in their working years. So that's really the other side of the coin of the success, is that we now have a different set of health problems which are affecting the same people who we've kept alive.
Thank you. Anna, would you like to add anything?
Yes, in terms of the strengths of the MDGs, I would like to point out that in addition to the 3 health-related MDGs, the overall focus on poverty reduction and on gender and on equality has been quite critical in terms of moving forward the health goals as well. Just to use one other goal as an example, MDG number 2, the one that's called Achieve Universal Primary Education, which is a goal that most countries have achieved, is so critical for health purposes too. I mean, we know how important education, schooling is in terms of maternal and child health. So although I totally agree with John, and I was going to point that out too, that the Millennium Development Goals, the MDGs have somehow contributed to siloed programs, it is also true that they have like cross-fertilized each other, and that progress in one of the MDGs has benefited progress in other MDGs. I already mentioned what everybody says, that the fact that they were so concrete, measurable, made such a big difference. Instead of being like a big statement, instead of being just something rhetorical, they encouraged action, which is great. Something interesting that happened that some of you from the donor community would know much better than me is that some big agencies, like for instance the DFID in the UK, completely restructured around the MDGs. I don't think that any other previous, UN level statement had such a big concrete influence on aid for international development. In terms of the shortcomings, I think that most of them have been mentioned. I would like to add that women's health throughout the life cycle is not included anyway, and that has to do with NCDs and other conditions that affect mostly women at later stages of their life. And integration hasn't been a focus either. And I would like to insist on the relatively low visibility of sexual and reproductive health. Whenever we all talk about MDG 5, it's always maternal health. We forget about that target 5B.
Thank you, Anna. Jono, a question to you. Why do you see universal health coverage as the leading strategy for improving women's health to follow the MDGs post-2015 in low and middle income countries? Is it not old wine in new bottles, as has it been described?
Okay, I would describe it as a foundational part, not leading, but a foundational part. Just a couple of words on what we mean, because people have a lot of different definitions. But it's basically, you can think of it as 4 A's: appropriate health care, accessible to all, affordable. That's the 4 A's. And in terms of women's health, it's the only approach that addresses all of women's health needs: the girl-child, sexual and reproductive health, AIDS, TB, malaria, chronic, other infectious diseases, and chronic diseases. The key to universal health coverage, and I think if you say that this is the sort of 21st century health for all, that can go both ways. But what's different is first of all, it's focusing on mobilizing and focusing all available sources of funding. A lot of it is about reorganizing domestic funding. Right now, we're in a situation where we have a number of the sort of upper strata, the low-income countries where economic growth is considerable. While we were melting the economy of the North from 2008 to 2011, there were at least a half a dozen countries in Africa that were growing at 5 or even 10%. Growth in the economy always fuels health spending, and if it's in a unstructured way, then what you grow is a very ineffective and imbalanced and inequitable health system. So it's about mobilizing resources and focusing them from all sources, domestic and international. It's about using those financial resources to leverage health system improvements. It's about providing protection against poverty. A mother shouldn't go bankrupt because her child needs surgery. But 100 million households, families a year, go bankrupt because of health expenses. And finally, it adapts to changing health needs. So you're building a health system that is flexible to address the different health needs. So you could say, just as we would expect from any 21st century society, to make a promise of primary education, not college education for everybody, but primary education. We would expect any 21st century society to provide universal health coverage for at least primary care. Not heart transplants for everybody, but at least primary health care for everybody.
Thank you. Anna, what are the special nuances that must be considered when designing and implementing universal health coverage programs to ensure that the programs meet the needs of women I would also say adolescents and girls.
Absolutely. Well, I think that in a few minutes we will talk a little bit about some country examples, and I think that we can learn a lot from some of the most successful universal health coverage type of programs. I think that the experience in Mexico, about which I will briefly, I will say a few words, the Seguro Popular, the popular health insurance in Mexico, has shown some of the features that a universal health coverage program needs to have. So the important point is not to let a particularly vulnerable group like women and children, for instance, fall through the cracks in terms of what they receive through a very broad, comprehensive program. And making the efforts to improve women's health in particular very, very explicit, and make sure that the package of services that are offered address, hopefully, the comprehensive needs of girls and women throughout their life cycle. In terms of the barriers, I think that successful programs all need to focus not only on the financial barriers that are definitely critical, but also do something about other equally important barriers, like gender-related barriers, or barriers related to lack of education, lack of information. In other words, that the program looks not only at the financial aspects of care, but other aspects as well. And finally, I think that when countries have a universal health coverage program in place, a good one, the women will also be supported not only in terms of their own health, but also in their roles as healthcare providers in the family and in the community. So a good UHC program should provide support, give women training opportunities, link them with the health system, so they can be more effective caregivers of their children, their relatives. Well, we know that women play those roles already, but they are not recognized, they are not valued, they are not supported. So I would say that a UHC program should do exactly that, value, even compensate, and support women in those roles. That's what we at the Women in Health Initiative at the Harvard School of Public Health focus our attention on.
Thank you. Maybe we can go into discussing some country-level examples of how universal health coverage has served and delivered for women's health. So maybe, Jono, if you would like to reflect on that, think about that.
Yeah, let me go to an unlikely place, Afghanistan. In December of 2001, when the Taliban were chased out of Kabul as the governing force, access to primary health care was less than 10%. There were basically no female health workers active anywhere in the country. Immunization was under 20%. 9 out of 10 women delivered without a skilled birth attendant. 9 out of 10, and Jeff's sitting there, he knows these data. 9 out of 10 women on their own for labor and delivery. In the year 2010, access to primary care was over 60%. There were an estimated 100,000 fewer infants and children dying every year than would have died the rates they were going at before. Family planning in large parts of the country had doubled, and in some places gotten to levels higher than what countries in other parts of the world had taken a decade to get to. And maternal mortality was reduced by at least a half. By at least 50% was half the. So how did that happen in a place like that? The First Minister of Health could have set a vision for building hospitals in the cities. Afghanistan had been through decades. That would have been politically appealing, but she didn't. She set a vision of universal health coverage for women and children with a focus on their health by putting, and number of us around the table had the privilege of working with her, Dr. Siddiqui. She said, let's have a package of essential services. We'll train midwives, hundreds of midwives from the community that went back to the community. The ones from Kabul that got educated in Kabul stayed in Kabul, but those in the outlying areas that came from there training thousands of community health workers, well over 20,000, half male, half female. And it was that design and mindset of a universal health coverage program, a number of other things, that actually got them to where they got in a very short amount of time.
Okay, thank you.
10 years in history is relatively short, I would say.
Anna, would you like to maybe further expand on the Mexico example or other examples? In relation?
Sure. For those of you who know me, you would know that Mexico is not an unexpected place for me to focus the attention on. It's my adopted home country. And I was there when the Seguro Popular was started by the current dean of the Harvard School of Public Health, Julio Frank, who used to be the Minister of Health in Mexico, with a total, not bipartisan, but multi-partisan support from the Congress, which was quite interesting considering how I see things happening here. So what prompted the creation of the national, Seguro Popular Health Insurance is that a study in the 90s that showed that more than 50% of total health expenditures were out of pocket, and that a large proportion of the population wasn't insured because insured was tied to employment, and in Mexico the informal sector is very, very large. And also that many people incurred in catastrophic expenditures due to the fact that they were not insured. So there was this proposal made to the Congress from the executive branch and approved by the Congress, as I mentioned, that established this program and also established a mechanism to keep its budget at a very good level. And there was this commitment to increase by 1% of the GDP, to increase by 1% the budget for health, 1% of the GDP, the budget for health care over 7 years. So at the end of that period, the budget for the health sector significantly increased. So the popular health insurance has a package of essential interventions, 250 interventions, that cover all the obvious interventions, the ones that have to do with maternal health, the most salient aspects of reproductive health, like family planning methods, that had been free in Mexico for many years anyway, but the package covers all of that, plus some, I would say, quite expensive and highly sophisticated treatments. Like, for instance, HIV/AIDS treatment is fully covered. Treatment for breast cancer is fully covered. Obviously, for cervical cancer, all children cancers are covered by the insurance. So it's quite ambitious, but thanks to that mechanism that was established to ensure that the budget was sufficient to cover that, I think it's been quite successful. It has also lots of problems, but in general, I would say that it's been quite successful. In addition to the package of health interventions, there were some other interesting features introduced. A strong focus on gender. They created a national Center for Gender Equity and Reproductive Health that not only monitored all the policies and programs focused on women, but also was like an internal mechanism to encourage some changes in the health system, like disaggregating health information by sex, which is something so obvious, but that doesn't happen almost anywhere. So once you have the health information disaggregated by sex, you can compare how things are going for women and men, at least for those conditions that they both share, both sexes share. Also, there was a strong focus on gender-based violence that didn't exist before, and something they called gender-sensitive budgets, which was an analysis that was done every year of the budget to see if the issues that disproportionately affect women got the budget they required to be addressed. Finally, I think that another very important lesson we can learn from that experience is that both the process and the impact of the popular health insurance are evaluated every year and on a continuous basis thanks to a monitoring mechanism. So it can be tracked what is happening in terms of coverage, in terms of access, and also in terms of some health outcomes. We know now that maternal mortality has significantly decreased in Mexico, although I don't think they will achieve the MDG 5, but still it has significantly improved. Child mortality has significantly improved as well, and many other critical indicators. So I would say that comprehensive view, the focus on women and children, the monitoring and evaluation mechanisms, also the opportunities that civil society and academics and other organizations had to participate in the process, I think were also very, very remarkable.
Thank you, Anna. So,
Could
John,
I just,
yeah,
sorry,
go ahead,
while we're
please go ahead.
on Mexico, could I just point out, there were three things there that were important that are ways that bring out at least three ways that universal health coverage can be misunderstood. One is that it has to be a big bang, and you got to do everything at once. They got to the 250 interventions by bringing them in over a period of several years. The second is that it's all about treatment. What Anna described, and there's a wonderful article by Felicia Null in the 2012 Lancet looking back at this, and there's a great figure there that puts the Seguro Social as one of three key parts of Julio Frank, the Minister of Health's vision on this, with the others being some of the equity monitoring and social determinants of health view. So that's the second thing. It's not just about treatment in the whole way. And the third is the sense that it benefits the rich more than the poor. If you look at the piece that was done a couple years ago on 32 countries, countdown countries, looking at inequities, child health and maternal health, the greatest span between the richest fifth and the poorest fifth were for the three interventions affecting women: family planning, antenatal care, and skilled birth attendants. So there's a big income disparity. If you look both in Mexico and Brazil, who's been at it 20 years and really measured it, because they focused on inequities, and that's a strength of some of the monitoring they're talking about for universal coverage, they addressed them. And so just three observations about Mexico.
No, thank you. My question was generally if a minister of health or a country came and asked for advice saying, we really want to move forward on universal health coverage, I mean, what would be, from the experiences of other countries, what would that advice be? What would you suggest? I think you flagged a couple of issues, but is there anything else you would like to highlight?
Well, I think getting a grip on the financial lever. I mean, one of the other, I hate to come back to Mexico, but they're good lessons there. One of the other things that the Minister of Health did was he knew he couldn't talk to Treasury, and he knew they were important. He found the best economists in the country, gave them a big office and a big title, and took them, you can ask Julio Frank, he'll tell you the story, took him to the Ministry of Finance with him. So when we talk about universal health coverage, each country puts the financing together in different ways. It's a quilt of financing. Ghana uses a value-added tax, and they use government revenues, and they use community-based health insurance. The key thing is that it's a little bit like Robin Hood. I mean, you get premiums in from those that can pay, but you are sure to use the public budget to target those parts of the population which would be left out otherwise. And the countries that do that effectively are the ones where you see equities actually being reduced with universal coverage. So that's one. The second is being really sure that you've got the high-impact interventions in the package. And if you're in a country, which none of us know countries like this, but if you're in a country where there are people that try to take family planning out of universal coverage, go to court, go to the streets, but get the package right. And the third thing is the social determinants. And back to Afghanistan, the way that they got family planning up there, because people started by saying, are they going to want family planning here? The answer was no. But when we actually got literally on the carpet and talked to the mullahs and all, what's in the Quran is child health and healthy children. So when the whole concept was reprogrammed, and we realized that if we talk in terms of healthy birth spacing, and we also get rid of all of the misinformation in the health workers, then in the districts where this was done, we saw doubling or tripling or sometimes quadrupling. So basically, get the financial lever, get the key benefits in there, and then really go after the social factors that influence and work through our own barriers to address those barriers.
Would you like to add anything, Anna? Or?
Well, you made me think about emergency contraception in Mexico that was included as part of this universal health coverage package. And, well, Mexico is a very Catholic country, and the Catholic Church is very, very powerful. So when first the Minister of Health announced that emergency contraception would be available for all women for free, there was this very, very strong pushback from the conservative groups. And it's important to remember that, Julio was the minister under a very, very conservative administration, so he had to move very carefully. But he put in place a very interesting process that I think it's another lesson that we could learn from that experience, which was to bring together researchers that produced, in some cases locally, and used the evidence that showed that emergency contraception wasn't an abortive agent. Bring communication groups that would make that message, that would disseminate that message in an understandable way to the population. Bring some civil society, commission some surveys that show that a large proportion of women that identify themselves as Catholic and religious were in favor of including emergency contraception in the package of family planning methods available. Because one thing is what, you're supposed to think and say, and another thing is what you would use in case you run into some kind of difficulty, right? I mean, it's just an anecdote, and I don't think that emergency contraception is one of the most important methods of contraception in Mexico or anywhere else, but I think that it says a lot about how to navigate those challenging areas in a creative and innovative way, and that can be successful.
Thank you, Anna. We really want to open it up to the audience, but just one final question to Anna and Jono. It's about how will we know if the universal health coverage programs are meeting the needs of women, and how will we measure impact, and what is the critical role of M&E, especially in terms of assessing inequities and also in the context of quality? Jono? Anna?
Measure it. One of the things in the article that we include is this examples of key service indicators, and I'll go over that in a minute. But whenever you're starting out a major global movement on something, monitoring and the measurement is an important part of that. And so, basically, what gets measured is what gets done. And at the global level, the global system, as it were, can probably only handle so many indicators. But I think what we all need to have in our pocket, and this is a starting in this improving women's health through universal health coverage, is indicators that we can put in real programs in individual countries. And it's the obvious stuff. It's contraceptive prevalence, it's unmet family planning needs, it's the indicators that the full range that we like in there, antenatal coverage. But it's also equity indicators, and so coverage of these looking, which is not reportable but surveyable periodically, is looking at that top quintile, lowest quintile, whatever. There's a lot of discussion going on about the universal health coverage indicators, but with the leadership of the World Bank and WHO, equity is an important part of that. My own sense is their equity focus is right on. The measures are probably really rough, and the countries can do better. So get the right measures, get them in early, hold the programs accountable, and be sure that we are looking at the equities. And it's measurable. I mean, so it's something that can be done. They won't all be global, but that's okay if we get them into countries. And the countries that have done that have improved equity. Full stop.
Anna?
Well, I think that Jono said it all, and that we mentioned most of the ingredients that need to be in place to make a universal health coverage program successful. I would just like to say that I'm a little worried about having a universal health coverage as the only sustainable development goal. I think that we as a community will have to be very smart to make sure that we don't lose focus, that we don't lose traction, that we don't lose what we've achieved over the last 15 years. And of course that we also address the unfinished agenda or the emerging agenda of issues that maybe we weren't so aware of 15 years ago. We didn't have the information, the evidence to know how important they are, like non-communicable diseases and other conditions.
Okay, thank you.
Can I come in on what
You can definitely come in.
just so it doesn't get misunderstood, I agree with you completely that with having the universal health coverage is kind of the one goal is probably not a good goal. There are different formulations. The one that I find most appealing is a goal around healthy life expectancy. No matter where you are in the economic development, people want to have a healthy and long life, most people. But then three components in that are, and there are measures for each of those components. What a lot of people are calling now the unfinished agenda, which is maternal health, child health, AIDS, TB, malaria. Keep that agenda there with measures and accountability. And there's, problem, disease, health needs specific measures and accountability are part of universal health coverage. And you can advocate for priority needs within it. So the unfinished needs, the chronic diseases, that's the epidemiology screams at that, and universal health coverage as a platform under that. Because if you step back and look at it, you can't get those other two major objectives achieved. The unfinished agenda and deal with a new chronic disease epidemic without an integrating platform that maximizes the financial resources and uses them to improve a health system. So that's kind of, and looks at equity. And that's at least the way that I'd formulate it.
Thank you. Thank you very much. So now it's over to you. If you have any questions, issues for clarification, can I ask you if you could introduce yourself before you ask the question? Thank you.
Hi, Mary Beth Hastings with the Center for Health and Gender Equity. Thanks so much for the discussion. Really, really fascinating. I just wanted to ask, the two examples in terms of countries that you gave had two ingredients that were the same, which was a health minister who was into it. And I'm just wondering if this is coming externally. Are there any examples of that being successful, of countries kind of taking this on, even though they don't have someone in that health ministry position who's really into it, especially in terms of some of the more difficult things on women's health? Abortion comes to mind, and some of those, EC. I was glad, Anna, that you mentioned the emergency contraception. But again, having an advocate for that seemed to be a primary ingredient for success. Thanks.
Thank you. Do you want to take a couple of questions and then?
However you want to do it.
Sure, let's take a couple of questions and then we can respond. I don't know, in terms of people online, would there be any people wanting to raise issues online?
Sure, they can ask via Twitter.
Okay.
And then one of our colleagues who's monitoring is going to work.
Okay, thank you.
Could you actually say that in a mic, though, so that online can hear?
Colleagues online, if you would like to raise questions, you can raise them through the Twitter address. Thank you.
Mary Ellen Stanton from USA. Thank you so much for this discussion. I wanted to know if you could talk a little bit more about what might be a perverse or negative consequences of putting universal health coverage up there. It seems so good, and it could cover survival and health. But we know that a lot of these services are really abysmal. Some of them violating women, issues of unnecessary medical procedures on one hand or utter neglect on the other. And if we seize on this, then say health expectancy or life expectancy, that could cover the unfinished agenda and the NCDs. I know there's been a lot of discussion, and you brought it up, Jonah, but a little more on that, because I think we could do a lot of work to bump the indicator or the goal that everybody has universal health coverage, and even with the core services, it may not give us what we would really want.
I'll take this last question and then we'll, yeah. Go
Hi,
ahead.
I'm Sarah Elkenbrock from Futures Group. I was wondering if you could speak a bit about the solutions that we could, as the development community, could present during the transition to universal coverage, because I think there's a lot of focus on the goal of universal health coverage without acknowledging that it takes a very long time in some countries to achieve that goal, maybe 30, 40 years. So I think we're very optimistic to focus on that and think universal health coverage is a panacea. So I wonder what the role of say conditional cash transfers and other financing mechanisms, vouchers perhaps, because we can't forget about those even if they're not part of the universal health coverage benefit package or whatever.
Mhm.
Thanks.
Thank you. Who would like to start?
Yeah, on the question about can it come in from the outside without a minister of health? There's a great Kenyan proverbs. Songs brought by foreigners are not long used at the dance. And lasting development virtually never comes from the outside. Good ideas can come from the outside, and know-how and financial resources. But you don't need a minister of health that's got the plot today to move forward. And I think what we'll see is that when nobody's done something, the whole conversation is about why it can't be done. But once it's been done in a few places, then the conversation starts being, how can we get what Ghana got or what Mexico got? And just to kind of put it in perspective, there are 50 countries that are, there are 30 countries that are pretty much at universal coverage, 95%. Those are mostly high-income countries, but some middle-income countries. Another 20 low- and middle-income countries that are on the way, and then another 50 that are sort of making plans. So I think what we'll see is populations in the country, civil society if it gets organized. I mean, I think if other groups are energized, they'll push forward. But you do need leadership. And you do need the government. The government needs to play a stewardship role to get it there. In terms of the perverse consequences and all of focus on universal health coverage, and the question about what can we do over time, the key thing is to have a vision for universal health coverage and build your system around that vision. If you take a graph I like to use is one that's got the average per capita health expenditures on one graph and the amount of excess preventable mortality. So how many people die that shouldn't die if we got all the health care? And if you take just 3 countries, U.S., Canada, and France, U.S. is twice on expenses per person and 30 to 50% more preventable mortality. So you say, how does that happen? It happened because of the vision. They were the 2 visions that grew those health systems. The Europeans had the post-World War II social equity, social safety net vision, and they had a vision of universal health coverage, and they grew a system on any of the measures. They measure 28 indicators every year those countries measure, and on responsiveness, access, cost, everything, the ones that had a universal vision got there. The vision that grew this health system was a vision of getting doctors and hospitals paid. And that vision's been realized richly, but it wasn't a health vision. So one point is, if you're growing a health system because more people are spending money, you want to have that vision. Along the way, if you look at how Thailand, which has been at this 50 years, as our friend says, they did have ad hoc programs focused to different population groups, but they pursued that with a universal health coverage vision that brought that together. So in the year 2000, they consolidated. So the key thing is, yes, keep working on target populations and underserved populations, but in the context of a universal health vision and bringing those programs together.
Thank you. First, the question about leadership. I think that leadership is quite critical, not only in the Ministry of Health. I think that leadership in Congress is absolutely critical. Leadership, in civil society or strong civil society groups. Professional associations also play a major role in terms of advising and legitimizing what the government is trying to do. So I do think that leadership is quite critical. Obviously, there are examples where leadership was stronger than, or places where leadership is stronger than others, but in general, I think that's definitely a condition that needs to be met. The perverse outcomes of UHC, I don't think that UHC is a panacea. I think that UHC will be built on the health systems, the culture, the government system that countries have, and will carry all those issues forward. I don't think that they will automatically solve them in any way. So I think that we need to be very aware of that and the weaknesses of the health system that you just mentioned. I mean, the poor quality of care, both technical and interpersonal, the undervaluing of women, since we are talking about maternal health and women's health today. So all of that will, hopefully will improve, and UHC will help to improve it, but it won't happen just because this new paradigm is embraced. I think that another very concrete risk that we mentioned before is the loss of focus. And that I don't only mean at the global UN level, but also at the district level. Usually these systems are highly decentralized, and this is something that we see in Mexico. Now, the states get a much larger budget to address those, or to implement those 250 interventions and address the issues that are relevant locally. But that also, that's great, but that also means that whoever is in charge may choose his or her priorities and neglect other things. So there isn't like a centralized structure that says, I don't know, family planning is free for all. Maybe there are, maybe it will be free for all in those states that don't think it's a priority, but they won't be available, or you won't have the wide range of methods that there should be there. Anyway, there are many ways to tweak the system. I think corruption is also a big risk because budgets are much larger, and the possibility of following up very carefully when the system is very decentralized becomes more unlikely. And finally, in terms of the perverse outcomes, I think that I don't know, I just thought about this, but maybe there could be an excessive focus on process. In other words, on access and on coverage, and not so much on outcomes that are so much more difficult to measure, and and that leads to, to all kinds of situations, including coercion, violation of people's rights, etc. Finally, the very interesting question about the process to get there. You're absolutely right. I was thinking about JSY in India and the voucher system in Kenya, and wondering if those would be incorporated into a universal health coverage program if adopted or not. I would like to hear Jono's perspective about that. We all know, or many of us know, what happened in India with JSY. I mean, the number of institutional deliveries skyrocketed, but maternal mortality didn't improve. And we know that the quality in those places, in the institutions that was relatively poor to start with, is now much worse, because now the same institutions with the same infrastructure, and probably not with many more health providers, are dealing with such a much larger number of women who go to those services. So I think that you are totally right that we will need, or governments or countries will need to follow up very carefully the process to ensure that it gets the health system goes in the direction that it should be.
Next round. Please go ahead.
Hi, I'm Jeffrey Smith from JPIGO and the MCHIP program. Fantastic discussion, and it's really stimulating. Thank you to all of you. I want to go back to the last question that Jackie had raised about the issue of monitoring, evaluation, and our metrics, because the question here is coverage. And for some interesting reason in the maternal newborn health arena, our metrics are quite different than they are in HIV or immunization. We don't have any metrics that are specific to key interventions. You know, in child health, you've got percentage of children with diarrheal disease who get ORS. In malaria, you've got percentage of women who slept under a bed net. In maternal health, we've got skilled attendants. We have no idea what that skilled attendant did. It's a contact measure, not a content measure. So I would be interested in knowing, how do you think we got here, that we have much worse metrics in maternal health than others have? And how, if we go towards universal health coverage, it's going to get even worse. It's just going to be, again, you know, someone came into the health system. How do we get a little bit more specific to know whether or not we're achieving what we want to achieve?
Thank you.
Oscar Cordon from Chemonics. Another thing that I would like to hear from you is also this necessity to have these accountability measures included in the monitoring and the evaluation of these programs, particularly in the decentralization context of the countries. I was just recently implementing a program in Peru, and it was interesting to know, for example, that the regional president, the closest context that he had on health was the number of water and sanitation systems in place. So besides what Jeff already said, how you go back to this local government and start talking about maternal health, it will be completely abstract to these people.
Thank you. We'll take these on Emily. Or is there a third question? Oh, sorry, please go
Hi,
ahead.
my name's Catherine Panther. I'm at USAID, and coming from the Office of Population Reproductive Health, I would like to thank you for your many mentions of family planning as an intervention in improving maternal health. So that's first. And I'd like to hear a little bit about the role of the public sector and the private sector in some of the possibly more successful or not successful. In some countries where we work, there's a distrust of the private sector by the public sector. In other countries, it works very well. So I'd just be interested in hearing, for universal health care coverage, what are the important aspects of how that relationship would work?
Thank you.
On Jeff's question, can you talk to us a little bit? I think you guys have a standard, what, you call it SBM, standard-based management, which does take it a step down, right? A step deeper. Can you say a little bit about that?
Well, I mean, that's a process, quality improvement process, and I think all of us are working harder to link those things to outcomes and which outcomes we should measure. But even, you know, if you look at the number of HMIS systems that have percentage of women who got a uterotonic at their birth, very few actually track it, and very few people actually can use that. And if they use it at all, it only reflects hospital births when 50% of the births are occurring at home. So, you know, the thing that concerns me is immunization. You've got DPT1, DPT3 rates. Everybody else seems to have great metrics for the things that count. And somehow we don't. And somehow we've struggled to develop and adopt indicators that mean anything that get at the major causes of mortality and morbidity.
Ellen, do you want to?
Yeah, well, you made me think about this, old debate about vertical versus horizontal programs. And probably universal health coverage is the most horizontal program, or primary health care. Those are, the idea is to strengthen the health system and then enable it to take care of the different issues that, you used immunization as an example. That's probably the paradigmatic vertical program, right? You have 1 day a year when all children are immunized, or a week a year when all children are immunized, and you can count how many, and you have the wonderful metrics that you just mentioned. I'm not going to say anything new. We always knew that to improve maternal health, you need a functional health system because there aren't any magic bullets. Even uterotonics are not magic bullets. The conditions require a different kind of approach. I don't need to tell you this. I think that's part of why we don't have good indicators. And there are many other things that most of you here also know, so I feel that I don't need to say this, but anyway, since you asked, the very weak HMIS, the very weak quality, or the very poor quality of clinical records, so many things that happen at home in the community that nobody registers, the inability of most women to report on what the provider did to her. We know that, DHS and other surveys try to collect some information from the users, but they are not a very good source or reliable source of information. So you mentioned that we measure mostly contacts, and that's definitely true. Most countries use as an indicator of the quality of their maternal health care, number of antenatal care visits. We know that doesn't mean anything. That usually women spend 5 minutes with the provider talking about things that are not so relevant for their pregnancies. So we need to look much more into the content. In other words, I don't have an answer, but I think that we need to work. We need to keep working much more and more effectively on indicators and measurement.
The one thing I would say is that I think in a well-managed universal health coverage program, I think you got a better shot at getting those indicators used, particularly if they're used in exchange for, if you don't report, you don't get paid kind of thing. And then you get monitored to make sure you're reporting honestly. So start getting, Oscar, if I think I understood your question, how do you get people, what good's a monitoring system if people don't want to do what you're monitoring? Was that basically, if they're not interested in the thing you're monitoring, how does that help?
No, I was saying that in the context of decentralization.
Okay.
In the context of decentralization, where, as Anna mentioned, for example, now budgets are larger, and people at that level have pretty much complete freedom, quotation mark, how they are going to allocate those budgets. Yeah. So I think the comment that you made about Mexico is extremely important. Leadership is not just in health. Leadership for maternal health and any area in health needs to include the Minister of Finance and needs to include other ministers as well. So this concept of health in all policies is extremely important. And because every 4 years you will have these changes, it will be more dramatic at the regional level in the decentralized context, because those people, the idea that they have of health is already abstract. Okay. And if we go back to the matrix of maternal health, if this president, for example, the closest idea of health that he has is a water and sanitation pipeline. How you start talking about maternal health, newborn health, and if we don't have the matrix to show them clearly, it requires from us creativity, but it requires from us also accountability. So I think the role of the civil society organizations in that perspective is extremely critical as well.
Okay, good, I got it. And that actually ties to the question from our colleague from Office of Population and Health. I had a very interesting experience about 10 years ago, visiting, and it struck me in two parts of the world, Guinea and Senegal, and then Indonesia and the Philippines. And in Senegal, we saw a hospital where women weren't delivering there. The reason was that a latrine was out back and nobody wanted to go out at night. They got the mayor involved. They had a twin city. They had the latrine built. Women were doing fine. Go next door to Guinea, and nothing was happening. All the accountability in Guinea was straight up to Conakry. The accountability in Senegal was nose to nose. Indonesia and the Philippines. I was visiting Indonesia, and they were talking about all the things that the project we're doing, and I said, but Indonesia, I'd been there a decade before, excels in those things. But it had all fallen apart because, again, accountability was up. Philippines went through a big bang decentralization. Very interesting, because health got cheated along the way, but a decade later, there was a whole movement of mayors. One of our staff they called the other MD. He was a medical doctor who became mayor. The accountability was nose to nose. Things worked in the Philippines that didn't work. So I think we have this idea about decentralization as if people way off in the capital are accountable. So what we saw looking at that is that when things get decentralized, which actually happened in Brazil also over time with their universal health coverage, then the key is to get the local governance working so that there's nose-to-nose accountability. And so if we go to Kenya, we go to the public-private. As an example, Kenya has a lot of private providers provided through their National Hospital Insurance Fund. 15 years ago, everybody on that board was appointed directly or indirectly by the president. And you can believe it wasn't a very efficient system. And through a lot of work, and this is where the development community helped because they helped restructure the laws and all, the board includes people from teachers, from the Christians and the Catholics, alternate who's on, the teachers, the employers, people who have a stake in it running well. And so there is accountability. And the only thing I would say on that is their current board, which is 13 people and has all sorts of stuff, only 3 of those are women. I believe that if there were at least half women on there, that they'd have a much even better decision-making. So universal health coverage, yes, will put more money in places. Governance is important, but getting actively involved and when it gets decentralized, educating people, because politicians figure out sooner or later that health touches every family. And if they succeed big there, they can succeed in the next election.
Completely around that integration. That's on March 10th, so we'll have that in the next week.
Just the one other thing, universal coverage, like Ghana, they do reimburse private providers, and if you and other countries, Philippines, PhilHealth, but if you use that to set up an accreditation process, so that you're using the money as a lever to improve quality. That's the way to do it, because it will if there's no either financial quality or health care delivery quality, the UHC program will go bust quickly. And actually, well, we won't go into that. But Ghana's had some problems getting that in balance. But at least they're going the right way, using the private sector in an appropriate way.
One quick comment to this question about the private sector. Well, it's inevitable. We as a global community definitely need to find ways to better integrate the private sector in the efforts we are making, considering the importance of the private sector. In South Asia, more than 50% of women who deliver institutionally, deliver in private facilities. And John already talked about regulation and accreditation. I just want to say a word about something different. I think that we should learn more from the private sector and better understand why the private sector is so successful in many places. And that has to do with the issue of quality of care and how women are treated. And sometimes, or very often, it's not the technical quality, because women could get better quality care in a public facility from a technical perspective. But they are treated more respectfully. The provider knows her name. They spend more time with the woman. So I think that I know that the private sector is very often seen, well, demonized. I think you used that word. But I think that we should let aside prejudices and try to create like more productive partnerships between the private and the public sector.
Thank you. Any final questions before we?
One last question. Claudia Morrissey Conlon. I'm with the Saving Mothers Giving Life initiative. I think universal health coverage as a goal makes a great deal of sense. My concern is definitional, that we have to agree as a health community, really led by public health specialists, not by necessarily physicians or professional societies, on what we mean by what we want to have covered. Mary Ellen made a point about, there are certain services that may be seen as a marker of being able to attain access to certain operations or other things that actually the outcomes are worse by that. So just kind of looking at the process of how we move forward with this notion, I really hope that we'll be very careful about how we define what it is we think this public health or primary care coverage is going to need to be, so that we do get our outcomes and we do have equity. So we can't have 70% specialists and 30% primary care physicians. We can't have midwives not being seen as the cadre to go to for birth. So I think this requires a more in-depth conversation about what we mean when we say universal health coverage. What exactly are we willing and wishing to have covered?
I've been told that we have more time for questions, so please, if you have questions, welcome them. Okay, I think, do we have anything on from colleagues online or tweets or?
For those monitoring Twitter, did any come in that perhaps we should share with the speakers?
Okay, I think we have been very efficient today, and we've really moved forward. Are there any, Anna, Jono, any? Oh, sorry, please go ahead.
Hi, I'm John Jay from MSH. I'm the middle author on this paper we've been talking about. So, like a middle child, I'm excited just to get the microphone for a second.
He's jet lagged.
Yes, I'm coming from a civil society meeting in Dakar. But what I'd like to announce for people whose organizations are interested in getting involved around UHC in post-2015 is that on March 1st, so over the next couple of weeks, MSH and partners will be launching a campaign of civil society organizations around a refined vision of UHC, so universal health coverage, but with a principled approach in the post-2015 framework. Just to explain that a little bit, what we hear is that many NGOs and other civil society groups agree to UHC in principle in the post-2015 framework, but want to hear clearer guarantees around human rights and equity, including gender equity and the availability of key services like family planning. Coming from the civil society meeting, I think there's very strong agreement that UHC is agreeing to UHC is really just the start of the conversation, and the rest of the conversation is how and what does that look like, in order to be able to buy into that. And so that's something that this campaign will be setting a clear standard of principles around, and we hope that your organizations will be interested in signing on. We'll be looking to target UN missions, the permanent representatives in New York who will be actually writing the SDGs. So if you would like to sign up, either for more information or to sign on to the campaign as it launches in March, the website is healthforallcampaign.org. That's all one word, and it's all words. We hope to hear from you. Thanks.
Thank you, John.
You know, I actually have a question. I think we've talked around it a little bit, but I was hoping that we could talk about it more directly. You know, when we've thought through JSY and how it hasn't had an impact on maternal mortality and such, I think and we talk about universal health coverage. There's and issues around respect and care, and we've talked about monitoring evaluation, but and indicators, but we haven't talked about it really from the healthcare force angle, and training and equity issues with healthcare force. So I'm just wondering if you have thoughts around that, if you've seen differences in some of the countries. I mean, you spoke a bit about the 50% male female when it came to outreach workers in Afghanistan. But I'm curious a little bit. You know, we've done a number of sessions now thinking about it from a health force angle, and I'm wondering if we could talk about that in this context as well.
Yeah, do you want to say anything about that?
Well, I want to thank you for reminding us of that dimension that we didn't, as you pointed out, discuss enough about. What UHC would mean for the health workforce, I don't know exactly, and John, I'm sure will have much more to say than me, but I do think that we need to have the health workforce very much in mind, because whatever, decisions we make in terms of the priorities or in terms of how to link the different programs and improve integration, or when we discuss quality of care, both from a technical and interpersonal perspective, we tend to focus all or most our attention on the users, which definitely deserve that attention, but we don't think enough about what all those high-level decisions mean for the person who is in the trenches. In the case of Mexico, just using the example I'm most familiar with, they made an effort to train new providers, midwives, mid-level providers in a health system that is highly medicalized to provide maternal health care to more women and try to increase the numbers and the quality of the health workforce. But that's something that deserves a lot of attention.
One thought on that, there was a wonderful story on National Public Radio about 10 days ago of a new discovery in one of the health programs in the U.S. It was this new idea of community health workers. That's the word they use, community health workers. The example they gave was this woman who was in the hospital every 6-8 weeks, and I think it was heart failure. It was a mess, and it was well over $100,000. They got a community health worker who went into her house and found out that she was just totally stressed out. I can't remember what she was totally stressed out about, but she wasn't, doing it. 3 months later, with this $15 an hour community health worker, the lady'd been out of the hospital. But I think the whole thing about the workforce, and I loved your comment, Claudia, about not over-medicalizing the thing. The health pyramid, the shape of a health pyramid in the country is probably the single biggest determinant of the average cost of the system. Whether there's lots of community health workers and a few doctors or lots of doctors. There are countries in Africa, Malawi was one, that wanted to sort of not have a, quote, double standard. And so they trained a lot of high-end doctors, nurses, whatever, who left. They didn't intend to make an export health worker business, but they did. And so I think the point that universal health coverage, if it expands resources and it expands demand, you got to have a workforce that fits it. But you've got to really have a conversation about what it takes to maintain that workforce. I mean, Afghanistan succeeded. I mean, the province, if you ever remember when the Taliban were there, shooting missiles into the mountainside and blowing up these Buddhist things. Well, that province, the first year that the provincial medical director set up a program for community midwives and all, it was like pulling teeth. It was just after the Taliban to get 20 young women to come for 18 months and be trained. The next year, he had to fight off the mothers of Bamiyan City because he wanted women from the community, from the rural areas. He lowered the education standard, but they came, they learned, they went back, and they stayed. And so I think back to the question about, I think it was a question about the downsides. If we create the mandate, get the money, but don't use that to redesign the system and just think that we can put people in facilities but not provide the workers. So it will push, when done well, the look at the human resources pyramid and get the right balance between a few at the top end and those at the middle and lower end. And it's got to go hand in hand. I mean, the whole conference of the Global Health Alliance, Global Health Workforce Alliance in Brazil last fall was around universal health coverage because they see that's critical. So people are thinking about it. Long answer to a short question, sorry.
Anything else? Anna? No?
No, thank you.
Okay. I think any concluding remarks or?
Well, 3 points from my side. I mean, I think universal health coverage is moving along. Countries are picking it up. We can sit here and do nothing, but more countries will continue to pick it up. Done well, it can really make a difference for women's health and for maternal health. It is the only approach that gets the girl child, gets sexual reproductive rights, addresses communicable diseases and non-communicable diseases. But it's really important to engage at every step in the process, in the design, in the legislation, in the implementation, at every level, with every means. If you have to go to the streets like they're doing in the Philippines for the Sexual and Reproductive Health Act that keeps getting bounced around or whatever. But get engaged because there are levers. There are points along the way, which some of those points Anna and John and I tried to point out, but the points we're getting in there, getting the right policies, holding people to account. So I wish you all well on that journey.
Well, I think we said it all collectively. Thank you so much.
Yes, no, just to conclude, thank you so much. It was a very rich discussion, extremely informative, and a lot of food for thought. And just a reminder that, the timeline is moving very quickly in terms of the post-MDG agenda, and just really to encourage everybody in terms of really keeping sexual reproductive health and rights really center in that agenda. So thank you very much. Enjoy the rest of your afternoon, and look forward to seeing you another time and another occasion at the Wilson Centre. And very much thank you again to Anne and Jono.
And to our chair. That was fun.